Good afternoon, everyone. Welcome to the third webinar from our series, Rheumatology Revealed 2.0, Advanced Insights and Evolving Best Practices for Family Physicians, hosted by the Office of Lifelong Learning and Physician Learning Program here at the University of Alberta. My name is Denise Campbell-Scher. I'm the Associate Dean for the office. Our office is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing the best care for clinical care for patients. University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Mi'kmaq, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, and Anishinaabe lands that are now known as Treaties 6, 7, and 8 and the homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. So just to go over a little bit of logistical information for the webinar, please use the chat feature on the bottom of the screen if you have a question about technical difficulties or L3 programs and services. If you have a question for the speaker, please use the Q&A feature of the webinar at the bottom of your screen. Please review what's already been asked and upvote those questions you'd like to have answers. We cannot guarantee that Dr. Clifford will be able to respond to all of your questions. A recording of the webinar will be sent via email to all those that registered, and participants can claim CME credits and complete a personal development activity using the My L3 Plan tool. For more information, please visit the QR code. This activity has not been formally reviewed by the CFPC or Royal College. However, it is eligible for non-certified credit. And Main Pro Plus participants may also earn additional certified credits by completing a linking learning exercise in your portal. So today we are very, very pleased to welcome Dr. Alison Clifford. Dr. Clifford will provide an update on how to recognize and manage giant cell arteritis. She completed medical school, internal medicine, and rheumatology residencies at Dalhousie University, followed by a 2-year clinical research vasculitis fellowship at the Center for Vasculitis Care and Research at the Cleveland Clinic in Cleveland, Ohio. She's currently an associate professor of rheumatology at the University of Alberta, where she has a clinical and research focus on vasculitis and is involved in medical education as the course coordinator for undergraduate MSK block. So thank you so much, Alison, for coming, and welcome to everybody for the webinar. I think people will probably be trickling in. So Natasha, maybe in the chat, put a little note around the recordings being sent out in a week or so, because we invariably get that question. Okay, Alison, I'm going to turn it over to you. Thank you so much for being here.
Okay, amazing. Thank you so much for having me. I'm super pleased to be here. I'm just going to see if I can share my screen. Is that working? Can you see it okay?
Yes.
Okay, perfect. Okay, amazing. Well, I think this was already said already, but this is me and my family. I think the only thing that maybe wasn't given to you was my email address. So I put it here on this slide. Just in case anybody has any questions, feel free to reach out to me directly. That's no problem. I have a couple of disclosures. I've done some industry-initiated trial work with AbbVie, and I've received some honoraria from UCB. But I think probably the most important disclosure for this talk is simply the fact that GCA is a rare disease and still understudied. And so throughout the talk, I'm going to try and point out the things that we know, and I think there are still many, many other areas that we don't fully understand yet. So kind of bear that in mind as we're going through. These were the objectives for the next sort of 40 minutes or so. Number one, I was going to go through what we know about the clinical presentation of GCA. In part two, we're going to discuss kind of how best to refer and what sort of options we have available to us for diagnostic testing. And then in the third part, focus a little bit more on treatment and adjunctive therapies. So starting with part one. So GCA, so what is it? There are very few slides. I think this may be the only one on pathophysiology. At its heart, GCA is a granulomatous vasculitis of the large arteries. And we are still learning lots about how this actually takes place. But basically, at its heart, as people age, a certain population loses immunotolerance for their own blood vessel walls. And so the inflammatory cells are entering the vessel wall through the vasa vasorum, which are kind of located out here in the adventitia. And then they crawl through the vessel layers. So they start adventitia and then migrate media and intima. And as they do this, they produce a lot of other inflammatory messages. They recruit their friends and produces a ton of cytokines and growth factors. Ultimately, what we see on the biopsy is inflammatory cells inside that blood vessel wall and a lot of vascular damage. So necrosis, destruction of the media, fragmentation of the internal elastic lamina would all be words that we tend to see on the biopsies. And if we kind of take one step back, how the blood vessel responds is really in only one of three ways. The first and most common way is that the blood vessel wall gets thicker. And so when we look kind of end on, it gets stenotic, and this translates into ischemia in those vessels. In some cases, it gets so thickened it occludes entirely, and patients will infarct. And then the third and sneakiest way is the blood vessel can balloon and become aneurysmal. This is the least common vascular feature that we tend to see, but it is the sneakiest because it's usually asymptomatic until something catastrophic like a dissection or a rupture occurs. And this is sort of a big picture look at how we classify the vasculitides. And I sort of highlighted GCA down here. It is classically considered a large vessel vasculitis. In fact, the most common one we see in North America. But what I like especially about this diagram is how they highlight it's a large vessel vasculitis, meaning it targets the aorta, but there's a lot of medium vessel overlap here. And so that's really important clinically in that we know the aorta is a target, but so are the temporal arteries, the subclavians, and the vertebral arteries, probably being the big four territories to bear in mind. So who gets a giant cell arteritis? Well, like most of our rheumatic diseases, it's a little bit more heavily weighted towards women than men. And by definition, it is a disease of older people. So patients must be over the age of 50 at the time they develop their symptoms, although incidence does increase progressively with age. And so we know that the peak incidence is around the 8th decade of life, with most people being closer to around 75, 76 years when they're diagnosed. And honestly, when I hear stories about GCA, the older the patient is when they develop their symptoms, the more suspicious this disease becomes to me. So it can happen at 50, but it is uncommon. It's much more common closer to 75, 80. This is the map of the global incidence of GCA, and what you can see is sort of the darker colors are where the higher incidence is. So it is reported to be most common in people of Northern European descent, particularly Scandinavia, Iceland being a real hotspot. And then here we see North America. And so here it's estimated that between 10 to 20 per 100,000 over the age of 50 will have GCA. But I think whenever we see a map that looks like this, all of these gray countries, we simply have no data. So almost certainly this is an underestimation. There's some really interesting studies that were done in Sweden where they would sequentially autopsy everyone in a certain city when they were passed away. And one of the pathologists identified that histologic GCA was found in close to 2%, so 1.6% of all patients who passed away, most of them who were asymptomatic. So we recognize it in this number, and I think we probably don't recognize it, and or patients may have no manifestations at a certain level. The other really, really important population to consider for GCA are those patients who have polymyalgia rheumatica. And so polymyalgia rheumatica, as we know, is kind of a periarticular MSK inflammation. And GCA on the other end is a true vasculitis. And really, I consider these two diseases as opposite ends of the same disease spectrum. We know that about 30% of patients with polymyalgia rheumatica will go on to develop clinical overt GCA. And on the other end, about 50% of all GCA patients will walk in the door with PMR. So these diseases are really very overlapped. In terms of clinical manifestations, patients with GCA present with constitutional symptoms, like we know, so fevers, night sweats, weight loss, fatigue. And then really cranial symptoms and visual symptoms tend to be the most frequent feature that bring patients to doctors. In terms of cranial symptoms, the number one most common symptom is that of a headache. The classic headache being the unilateral temporal headache. But really, in real life, I think all headaches are described bilateral, temporal, occipital, facial. The only uniform characteristic is it tends to be a headache unlike any other headache the patient has experienced before, and it tends to be persistent and not responsive to over-the-counter analgesics like Tylenol or Advil. Scalp tenderness is a little bit more specific, and patients will often describe pain when they're brushing their hair, washing their hair. I had one patient who said like the wind blowing across her scalp would bother her. But jaw claudication is really the most specific symptom. And so true kind of fatigability of the jaw muscles is really quite suspicious for this diagnosis and very helpful. Vision loss is the reason we consider it an emergency. This can be partial or it can be total loss. It tends to be early, sudden onset, painless, but sadly permanent. So most cases, once the vision loss has occurred, we don't recover that vision. We do still treat these patients quite aggressively because once vision is lost in one eye, there's a really high risk, approximately 50% of losing vision in the second eye within the next week. So we do still advocate for early aggressive treatment of those patients. And some patients will have amaurosis first, which is a warning sign that they are about to lose complete vision in that eye. A few patients will have diplopia. That's a little bit less common of a symptom, but thought to be due to ischemia of the extraocular muscles. Can't co-occur. This is just a picture of all the different blood vessels we know are affected in GCA and sort of how they relate. So this is the superficial temporal artery. We think it's stenosis and occlusions in like along this branch of the artery that lead to the headache and the scalp tenderness. Involvement of the facial artery leads to the jaw claudication because of supply issues to the masseter muscle. And then maxillary artery, fascinating, also involved. We can see it on PET scans. So down here in the circle, you can see inflammation of the superficial temporal artery, but over here you can see maxillary artery involvement too. So some patients will present with almost more this sinus pain headache, and they have vasculitis in there as well. Up here, we see the blood supply to the back of the eye. So the vision loss is most commonly explained by ischemia or infarcts in the ophthalmic and posterior ciliary arteries. Polymyalgia rheumatica is a really common symptom in these patients, about 50% upfront. Kind of poorly localized, but very symmetrical pain to both shoulders and hip girdles with a lot of morning stiffness. When I was doing my training, I was really perplexed by PMR because I couldn't figure out what the target was. You know, in rheumatoid, we know that it's the synovium itself that is targeted. In PMR, I think we now understand this disease better, mostly because of PET scan, where we can really see that the inflammation is usually not the synovium itself, but sort of the periarticular structures, the capsules, the entheses where the muscles are, and the bursa. So around both shoulder girdles, and again, around both hips and buttocks areas too, especially like ischial tuberosities. And again, around the knees where patients will often complain of pain, but maybe don't have true joint swelling. So more like a muscle attachment inflammation happening in these patients. Oh yeah, this is one of my patients who has interspinous bursitis on her PET. So also a very common manifestation in PMR. In addition to affecting the temporal arteries, we know that most patients with GCA have large vessel involvement as well, so 70%. So odds are they will have this. Most common target would be the aorta and its proximal branches. So within the aorta, the thoracic aorta is number one. Usually this is going to be asymptomatic, but can produce aneurysm over time, usually silent. The vertebral arteries are a very common target, and patients will most often get stenotic in here, which puts them at risk of stroke. This is usually an early manifestation. And then the subclavian arteries would be the third most common target. Again, very often asymptomatic, but patients can present with loss of pulses in the arms, which is a really good clue. physical exam of GCA, we sort of go after those blood vessels. So some patients will come in like this gentleman with a visibly swollen artery. That's a very helpful sign, but not often present. An absent pulse would be the next best clue. And so I like to feel kind of just anterior to the ear where there's a common branch of that artery where pretty much everybody has a present pulse. But an absent pulse is a nice clue for GCA. And then a tender temporal artery pulse would be the third most useful finding there. An excellent eye exam is also essential for these patients, especially anyone who has had vision loss. My fundoscopy skills are quite poor, I would say. And so anyone with vision loss, I also refer to ophthalmology for a really excellent eye exam. And then we do cardiac and vascular exams, looking for blood pressure asymmetry, usually because of subclavian disease, absent radial or brachial pulses being very suspicious. And then we listen for aortic insufficiency murmurs, which are really hard to hear, I think, but worrisome when found. We do an exam for PMR, and then really importantly, I think, because headache is the most common manifestation and not a particularly specific one, a good exam looking for other explanations. So any kind of neuro explanation for headache or ENT findings would kind of start to point away from GCA. That was section 1. In part 2, we're going to talk about how to refer and how to work these patients up. So GCA, I think one of the hardest things about this disease is we have very few labs that are sensitive or specific enough. When seeing these patients, we usually recommend blood work as soon as possible, same day if you can. I like to send a CBC diff. I like ESR and CRP. I know that's hard for many people to get the ESR now in clinical practice. And then creatinine and glucose. Glucose not essential for the diagnosis by any stretch, but step 2 is usually the prednisone. So it's nice to have a baseline glucose to see where we're living before we add that in. In GCA, we expect to see a normal or sometimes high white blood cell count. It's usually neutrophilia. Leukocytosis would be distinctly uncommon and make me start thinking about something else. Normocytic anemia from chronic inflammation, a reactive thrombocytosis, and then ESR and CRP are usually elevated. The classic teaching is that they're dramatically elevated. So inflammatory markers over 100 would be very much in keeping with this diagnosis, but sometimes they're only moderately elevated, 30, 35, and that could be GCA too. I put a word of caution, although most people will have an elevated inflammatory marker, we know that about 5% of biopsy-proven cases have a dead normal ESR and CRP. And that's true in data from other countries, and it's also true of our local Edmonton data. One of my students looked through all of our proven cases over 5 years. And this is why I like to send both ESR and CRP. About 20% of patients have either one normal, but only 5% have both normal. So if you're able to get both, it is helpful. And if they are both normal, but you're still very suspicious of the diagnosis, you could be right. We should still be working them up. I kind of put, for those of you who have Connect Care, this is how I get the ESR done. It does often get canceled if I don't go through these steps. So I took some snapshots. I don't know if this is how Connect Care appears for everyone else as well. But when I put in ESR, I get this reminder like, hey, is this person on a biologic or no? For GCA, if I hit no, there's a list of other diseases for which we are still able to send ESRs. And GCA is one of those conditions. So if I hit those 2 extra boxes, the ESR usually gets processed. If I don't, they do get canceled. I think if you don't have Connect Care, this may be hard to do, in which case CRP is still excellent. And then once the blood work is back, there is a very nice provincial care pathway for GCA that has been published. I think it came out almost a year ago now, but I don't know if everybody's had a chance to see it. I put a shot here and then I made it bigger because I had a hard time reading this. But it's a very good pathway. It was written by Dr. Steph Garner, who's a rheumatologist down in Calgary and also sees a lot of GCA. And we had a look at it too. I think it's very clear and nice for following. It goes through the history. It goes through the big red flags, particularly vision loss. So if the patient has vision loss up front, this would be a very reasonable call to ophthalmology because they will see these patients emergently, like usually that day, to help figure it out and start treatment if they need it. If there's no vision loss, Then it kind of goes through the physical exam and the stat labs to send. And then once you have that back, you can do the South End probability score. And same thing on the AHS pathway, there's a link right to this score. I have some pictures of that on the next couple of slides, but it's quite user-friendly. It takes a couple minutes probably to do. And then what it will spit out is the patient's risk of having GCA. So either low risk or intermediate high risk. If the patient is intermediate or high risk, the best way to refer these patients, I think, is to call the rheumatologist on call. So this can be done through Rapid, and Rapid will find whichever of us is on. That way we can have a discussion, we can talk about starting prednisone, and we can make sure we get that patient in fairly quickly and get the rest of the testing lined up. I think that is probably the fastest and best way to do it. If the patient is low risk, actually it's most likely that something else is going on. And same thing on this pathway, they give like a list of other most common alternative diagnoses, so other things to consider. And then same thing, if you still feel at the end of the day like this is probably GCA, of course you call us anytime. We're always happy to talk about these patients on the phone for sure. This is what that probability score looks like. It's pretty user-friendly, I think. You need to have just sort of a couple key pieces of information about the patient. So I sort of plugged it in, pretending this was an older woman with about 3 months of headache. Her CRP was over 25. What else did I put on here? Headache, PMR, but no constitutional symptoms, no ischemic manifestations, temporal artery tenderness on exam. And then the last part of this score is whether or not there's a better alternative diagnosis. So that's a very important part too. But could there be infection? Are there any signs of cancer? Do they have another rheumatic disease or known head and neck pathology? And then right at the bottom, it will spit out your score for you. So my patient came out as high risk for GCA. So this would be a perfect phone call to rheumatology. And really, when the score was evaluated, it had really good sensitivity and specificity for determining the diagnosis. Okay, so once the suspicion is intermediate to high, most of the times we are going to suggest empirically covering with prednisone. The reason being that risk of vision loss and the risk of stroke is highest in the early days before we figure it out. So we usually empirically treat and then hunt down more investigations. Temporal artery biopsy, I think, is still a super important test in this condition. I think there will probably be some questions about how best to do this. I'm happy to answer that at the end because a little bit depends on where you are. Nevertheless, I think it's a really good test for this disease. It's done under local, patients are awake, very few adverse effects from this procedure. They can have a little bit of persistent pain afterwards. Some patients need a little bit of their hair shaved in order to do it. But the benefits are that if we see histologic proof of vasculitis, we sort of have the diagnosis clinched. And really, these patients get a lot of immunosuppression. So we very much like to have the best story and the best confirmation up front. The specificity of the biopsy is really good. The sensitivity is a little bit lower. And so that's an important caution that not everybody with GCA will have biopsy-proven disease because we know it's a patchy disease. So it can be here and then skip another lesion, and the biopsies are done blind. But really, I think it's a great test. And one of the questions I think I get the most is whether or not it's still useful on prednisone. And my answer would be definitely yes. We know for sure that the best yield is the fastest biopsy. So within 2 weeks of prednisone, we'll give you the best quality specimen. But there is evidence showing that even down the road, the biopsy is still quite high yield. There's a really nice study from the Mayo Clinic where they repeated the biopsy on the contralateral side at 6 months, 12 months. I mean, still 75% of patients were biopsy positive, even after 6 months of treatment. So these infiltrates are really slow to resolve. So my general recommendation is if we're not sure it's GCA, it's generally a good idea to do one. But we have other options, which is really exciting. So in addition to tissue confirmation, our options for imaging are now a lot better than they have ever been. And when I think about imaging for GCA, I think about the cranial vessels and I think about the extracranial vessels because it's sort of the ways we can organize. when I was thinking about this talk, I was thinking predominantly about Edmonton, but even Alberta-wide, if we think about options for imaging, so things like CT angiogram, chest, abdomen, pelvis, I think this would be pretty widely available. The benefits of this is you're going to get really nice pictures of your vascular anatomy, and especially those like common big vessel targets, so the aorta, the takeoff of the vertebrals and the subclavians. I think the limits of this modality is you're not going to get a lot of information about activity. And for me, at least, I think the timing of it is troublesome in that it generally takes me at least a couple of months to get this organized. So this is a harder test to get quickly, I think, but it can still give you really nice information. What tends to happen faster is our PET CT. And I think we are really lucky in Alberta in that we have really excellent PET access, which is not necessarily true across Canada. What PET does is by using FDG, it shows us inflammation in those big blood vessels. And also, really importantly, it can look for disease mimics. So infection and malignancies will often also light up on PET. So it gives us a lot of nice information in one shot and really whole body. So the scanners have improved a lot even over these last couple of years, where now we can see the temporal arteries on these scans, as well as the aorta and big vessels. Main issue with PET is that it is definitely altered by prednisone. And so the earliest PET scan is going to be the most useful. Within 3 days of starting steroids, it looks like equivalent to pre-steroid. After 3 days, the yield does go down. It can still be useful, but really the best quality test is going to be the fastest one. And so again, I think when we're talking about these patients on the phone, we can often help expedite a PET scan for patients who live at least close to one of the major centers to see if we can help get this arranged. Oh, these are pictures of PETs. So I am not a radiologist. Full disclosure, this is one of my patients. I think even not being a radiologist, some of these pictures are so striking. So this is a patient when her vasculitis was quiet, and this is when it's active. And this is what we're looking for, sort of this long, inflamed segments of arteries, very symmetrical, but bilateral subclavians, bilateral femorals, very suspicious for GCA. These are more pictures kind of looking at the aorta, it's both thoracic and abdominal. And the sensitivity specificity is pretty good for this diagnosis. Okay. Looking beyond PET, there's also a lot of interest in temporal artery ultrasound. This is a great modality. It's going to be more targeted to the superficial temporal arteries and all the branches, and then also usually includes the axillary arteries as well. Benefits is it can be done point of care, and there's no radiation. It can help make decisions quickly. What you expect to see is this, what we call halo sign. So it's sort of a thickened hypoechoic vessel wall kind of surrounding that lumen. And really in folks who are doing this a lot, the sensitivity specificity is pretty good for the diagnosis. Main limitation to this is access, I think, in that it is very user dependent and requires quite a bit of training to be able to do this. So this is not available widely yet in Alberta, but there will be some access in a few places for sure. When available, it's a great test. Had a little bit of information about what happens with our GCA referrals here. I may be able to show it really quickly. One of my students looked back over the last couple of years and identified the new referrals to us here at the university center. So there was a little over 80 of them. As you can see, most of them did come from family medicine, as we would expect, with the rest from ophthalmology, emerge, and a few from other places. Again, we try to get these patients in as fast as we can. The average was about 9 days. And then sort of as we would have expected, most patients are going for a biopsy. So 80%, with 40% getting PET, and then a few getting temporal artery ultrasound. What I was impressed with was this number, which is of the patients who are sent to us, 65% of the time we agree that it's GCA. And again, most of these patients are being confirmed by another diagnostic test. And then in the patients in whom GCA was excluded, these were the alternative diagnoses. So migraine, trigeminal neuralgia, medication-related headaches probably being the most common alternatives. Okay, in the last section of the talk, we're going to talk a little bit about treatment and follow-up. So treatment of GCA still relies really heavily on prednisone. Prednisone is our first line, fastest acting drug. When we're using it in GCA, we usually recommend about 1 milligram per kilo per day by mouth, and most of us would max out around 60 milligrams per day. If there's any worry about sight-threatening disease, so vision loss, amaurosis, it's reasonable to consider admitting that patient to hospital for IV steroids, really to try and stop the disease in its course and save the other eye. And generally, if somebody's at intermediate or high likelihood of GCA, we suggest starting it right away and then pursuing those other tests. Historically, we would use, and still sometimes, we are using prednisone monotherapy for these patients. And when that happens, what we know is these patients will get quite a lot of prednisone, with the average course running somewhere between 18 months to 2 years. At the end of their first course of treatment, most of the literature suggests that about half of patients will be fine and not need further therapy, and the other half will relapse. And so particularly in that relapsing group, there are a lot of side effects from the prednisone, like we would all expect. You know this as well as I. These are all the side effects we see with glucocorticoids. They are truly a double-edged sword in that nothing works as fast or as well, but almost nothing else has as many side effects to the patients. I put little red stars above the first two, bone loss and GI disease, because those are the two that happen so frequently. We usually aim to prophylax everybody against this. So everyone with GCA, when we're starting steroids, we suggest calcium, vitamin D, and bisphosphonate or another bone protecting agent. And for most of these elderly patients who are going to get high dose prednisone, I would suggest a PPI. The next three, I put blue stars, again, because we don't traditionally prophylax against them, but I think they happen so commonly and often, require help managing. But mood disorder and sleep disorders would be super common. Hyperglycemia, very common. And then infections, unfortunately, especially in the early days when the doses are big. And so patients, have all kinds of feelings about prednisone. I think like us, they both love and hate it. And so, I put this in. I'm not sure if everyone is aware of this website. If not, I just wanted to put a plug in for rheuminfo.com. This is a really lovely website. It's created by Andy Thompson, who's a rheumatologist in London, Ontario. It's got lots of great information, actually great for patients. But what I use it the most for is honestly his medication handouts. If you type prednisone or any other, rheumatologic drug name for that matter into this bar, I mean, you can see Andy talking about it in a video, but if you click this quick reference guide at the bottom, it'll pull up his patient handouts. And so for prednisone, I will be giving one of these to most of my patients. It's nice and easy to read, and it reminds patients of the most important things to monitor for. So it's a really nice resource if you haven't seen it before. Prednisone works, and it works very well, but because of the toxicities, there's a real movement in GCA to try and add early steroid-sparing medications. And really the one we have the best evidence for to date is tocilizumab. And so tocilizumab is a monoclonal antibody against the IL-6 receptor. Many people would be familiar with it from rheumatoid arthritis, where we've been using it for quite a few years. Tocilizumab is approved for all GCAs by Blue Cross and by most private payer plans. So a new GCA or a relapsing patient would qualify for tocilizumab, and it's usually approved for a 1-year course. And it was approved this way because there's a large trial showing that when you add tocilizumab to prednisone, it allows us not only to significantly reduce the risk of their relapse, but really importantly, it shows really nice steroid sparing. And so usually what I quote to patients, it doesn't mean that people get away with no prednisone, but in general, most patients will get away with about half as much prednisone. So most people will come off of it by 6 months instead of that 12 to 18 month mark, which is still a really good outcome, I think. And so this is a medication that is something we can offer to all GCAs, and another reason why we're really happy to see these patients in rheumatology. Tocilizumab, although it does reduce relapse and it does spare steroid, I don't think it changes the natural history of the disease. After the 1-year course, what we tend to see in the literature is very similar numbers. About half of patients will stay in remission off all drug, and the other half will relapse and need retreatment. And so after that 1 year, we can then reapply for subsequent courses, but about half of people will be okay. Important issues with tocilizumab. So tocilizumab works, but very similar to like all of our biologics, when we add it, there's a small increased risk of serious infection. It doesn't look in the literature like this is above what happens with prednisone monotherapy. I think because it is so steroid sparing, we don't tend to see more infections, but we do still see them. And it's important to recognize, so if this patient is on tocilizumab and they're sick or they're febrile, we always tell patients to hold the medicine until they're resolved, until their antibiotics are completed. And then they can go back on, because it will make it harder for them to recover. And the other sneaky thing about this medicine is that because of its mechanism of action, it basically blocks hepatic synthesis of CRP. So once our patients are taking it, and this is true of our GCA, it's also true of our rheumatoid patients, they generally don't mount a CRP anymore. So even if their disease is flaring, or even if they develop an infection, their CRP looks beautiful. And it's because of the way the drug works. It also significantly lowers the ESR, although the ESR is a little bit more reflective. So most of my patients who are on this drug, I try to follow both markers. And the important thing with that for us to recognize is once they're on tocilizumab, their CRP just isn't reliable anymore. We really have to go based on their clinical symptoms and or their imaging. Other adverse effects are possible with this medication, but kind of unlikely. The one strange one I did highlight in red, which is we know that tocilizumab can increase patients' lipids. Still a bit unclear what the clinical significance of this is. We do have recommendations that once we start this medicine, usually we suggest the patient's lipids are retested sometime that next year. And then they should be managed as per the usual guidelines. But it is a drug-related effect. So tocilizumab has the best evidence to date for steroid sparing in GCA. There is a new option, which is pretty exciting. This just came out earlier in April, so just a few weeks ago in the New England Journal, which is the results of upadacitinib for GCA. And this was the SELECT GCA trial. So upadacitinib, or Rinvoq, same thing, has been on the market for a few years now, particularly for rheumatoid arthritis. So there is experience using this in other diseases, also IBD. Very similar to the way the tocilizumab trial was designed. This was a very, very large trial of GCA patients in multiple countries, and designed with a similar steroid-sparing protocol. They were able to show also that upadacitinib reduces the risk of relapse and spares prednisone. I highlighted less overall infection than placebo, but important to note this was not statistically significantly less infection, but just numerically, so not more infections than placebo. This drug is not yet approved for GCA, but I have a feeling it may be available either later this year or potentially next year. So maybe something to look for in the future, although we generally don't have access quite yet. In terms of adjunctive treatments, historically, I think most of us used to say aspirin for everyone with GCA. The tides have shifted a little bit on the feeling about aspirin, only recognizing that we have very limited evidence to suggest that it is helpful. So probably it's not needed for everyone. There is some retrospective data suggesting it reduces the risk of vision loss or stroke. Most recommendations suggest that if the patient needs it because of stroke, because of cardiovascular disease, or if they have really critical stenoses in important arteries, it's reasonable to add on, but probably not every GCA patient needs this. We do, however, recommend that everyone who is getting more than 3 months of prednisone go on bone protection. So this would be pretty much all of our GCAs, and GI protection. recognizing that they are older and they will get a significant dose of prednisone. In terms of prognosis of GCA, overall, there's no increased mortality in this disease. However, there's a high mortality in some subgroups. Particularly the first 2 years from the diagnosis is a high risk time for these patients and those patients who present with stroke. The third group that we pay close attention to are those who have developed aortic damage. So patients who have dilatation or aneurysm, especially in that thoracic aorta, need to be monitored, usually yearly with imaging. In terms of mortality, the number one cause of mortality in these patients is cardiovascular disease, followed by cerebrovascular disease, and then infection because of the immunosuppression. And then last but not least, I had a slide about organ damage and monitoring. So vision loss still affects somewhere between 6 to 15% of our patients. This tends to be an early manifestation, most often before the disease is recognized. Once patients are on treatment, it's distinctly uncommon to lose any vision. Same thing, stroke is more rare, but affects somewhere up to 4%. It's usually posterior circulation. And again, usually in those first couple of weeks when the disease is most active. And then aortic aneurysm is the opposite, tends to be a long-term consequence. Once a patient is 5 years out from their diagnosis is actually when the trajectory tends to take off. And so this is one of the manifestations that we follow more carefully for over time, particularly in patients when we know they've had aortic inflammation. And so generally, we tend to follow these patients lifelong, knowing that 50% of them will not relapse, but even those who don't will be at some risk for aortic aneurysm potentially. So that is sort of the 3 objectives that I had planned for. I have a couple of resources at the end I'm happy to show, but I'm also happy to pause here and see if we have any questions. So maybe I will pause first and see how we're doing.
Awesome, Alison. Thank you so much. Yes, we have some questions coming in the Q&A. Just to remind folks, please use the Q&A button on the bottom of your screen. And Tina made a point under the chat, which I just want to echo. So she was talking about, a lot of people in Calgary will use the specialist link, and GCA is on the provincial pathway PDF. So Natasha, maybe you can pull that helpful link that Tina provided over into the Q&A so all the participants can see it. And Jean-Pierre is asking the question, which giant cell arteritis should be screened for with aortic disease, especially aneurysm? I think, when should we maybe be doing a little bit more of a vascular look on patients who've had GCA?
That is a really good question. So,
for you?
Sorry?
The other question of that is that for me or is that for you? So are these things family docs should be monitoring?
Oh, yeah. I mean, great questions. Yes. So, so you're talking about like once we know a patient has GCA, does everybody need to be screened for aortic aneurysm? That is a controversial question. Different groups feel differently, I would say. In my practice, so it's not across the board, everybody agrees on this. That is definitely true. What we know is most patients are going to have large vessel inflammation. When you look at prospective imaging studies, about 15% of GCA patients have aortic dilatation, usually thoracic aorta at baseline. So it's not most of them, but there's that chunk, right? That 15%. In my practice, I usually will do at least a one-time CT chest. If I don't have a reason for doing a PET CT, say for my diagnosis, I've already clinched it, like we know based on biopsy what it is. I will usually try and do large vessel screening at least once in that first year, just to try and catch that 15%. Once you know someone has large vessel damage, then again, most of us would agree that it probably should be followed in some way because usually patients have no symptoms from it until something catastrophic. Most people would re-image every 1 to 2 years. depending on if something would be done for that patient. So if the patient is still of an age where they would be considered for surgery to repair it, it's reasonable to follow it. So I would usually do it sometime up front, but if I don't need it for my diagnosis, it's not emergency, I'll just try and get it sometime that first year.
Okay, and just to clarify, would that be a CT or CTA?
Yeah, it would be a CT angiogram. Yeah, for sure. Yeah.
Yeah, so Hector has a question, and don't be shy, guys. We can fill in the Q&A box. So he asks, if we have a patient on TZZ plus prednisone
Mm.
and they experience recrudescence, in press word, when lowering the prednisone or discontinuing after 6 months, do we increase or reintroduce the prednisone or start with the protocol from scratch?
Oh, so if they flare while the prednisone's being tapered? Yeah, it depends. It's a good question. Yeah, so it depends what the manifestation is. I don't necessarily always go back to 60 if it's not something critical organ threatening. I will usually try going back to the last dose of prednisone where things were good. When someone is on Actemra or tocilizumab. And then, and then I try and double check all the things. Are they taking their tocilizumab? Are they taking their prednisone? There's often a lot of mix-ups because it's really hard to do these kinds of tapers. I always try and confirm, are the patients actually taking what I think they are as well? And then if the patient has really relapsed, and the other thing I guess to pay close attention to is that timing of tocilizumab. We know that prednisone works within hours, which is why it's so great. Tocilizumab does not work within hours. It probably takes closer to 3 months to really, really be in the system. And so I wouldn't necessarily say they had failed it if they were still in those early couple months of starting it. Later on, there's other things that we will consider. Some people add methotrexate to the tocilizumab with the prednisone. There's some data for secukinumab, which I didn't present. And then again, we do have upadacitinib coming in. But I don't know if that helped. I would usually go back to the last dose of prednisone, unless it was something really evil. Vision loss, that would get my attention. And maybe I would go, right back to the high dose. TIA types of symptoms, those would be really worrisome.
Interesting. Yeah, I was just surfing around that room info page, and there was a really neat tool for prednisone taper. Type prednisone in the box, and it prints a whole little map for your patient with all the dates. And I was like, oh, I'm going to start using that.
Yeah.
And that recrudescence, Hector, I'm intimidated and impressed.
Yeah.
Recurrence of an undesirable condition. So that's our word for the day. Okay, so a related question from Wendy around the tocilizumab, asking around whether that's used in PMR, if there's difficulty with tapering the steroids. Is that when that comes in? That's what Wendy's
Yeah, tocilizumab for PMR. Depends. So tocilizumab approval, you have to have GCA, but once you have it for GCA, many patients' GCA symptoms will include PMR. Tocilizumab does work for PMR. There's nice data to support that. If it's a pure PMR patient, actually the best data is with sarilumab, which is a different but similar mechanism, anti-IL-6 biologic. So it depends a little bit if you have that concomitant GCA PMR diagnosis or if you're more a pure PMR. If that makes sense.
Yes, it does make sense. So Jean-Pierre just is on a related question, asking about sort of how to then look at metrics for following the tapering. Because I believe, if I captured correctly, Alison, when you said with the tocilizumab, you don't see the CRP.
Yeah.
It wouldn't be, so he asked whether it's CRP, PET, or myalgia response. So it wouldn't be CRP.
Yeah.
So
How do we get, yeah, it gets really, tocilizumab is great, but it does make things harder, that you're really dependent on your clinical assessment. ESR is less influenced, but still influenced by tocilizumab. So I like, it's one of those cases where I really try and get the ESR done too. And then we rely very heavily on clinical symptoms. And it's one of the places where I also would tend to re-image. The evidence around this is very poor and or controversial. So it's definitely not standard of care to say repeat PET in patients with GCA. But I sometimes will do it, not planning to hinge my whole treatment on the PET, but to use it as sort of a surrogate. If I'm worried they're flaring, the PET looks worse. Now I have a little bit of proof. Um, Still ultimately it has to hinge on how the patient is doing. So really trying to nitpick with them. If you think things are coming back and it's GCA related, it could be. Um, Definitely we see that. A good chunk of patients, I think, especially in my practice, they don't come right off their prednisone, although that's what we love to see is like, oh, we're going to put them on tocilizumab, they're going to be steroid free, it's beautiful. I don't think that happens as often as we wish it would. I have a lot of patients who do, the tocilizumab I think helps, but they get down to like 5 of prednisone. And even 5 of prednisone in my books is still a good benchmark. We know there's definitely still toxicities associated with it, but they're much lower than 10, 15, 20. If I can get them to 5, I start to breathe like a little bit of sigh of relief that at least we're in a safer space now.
Okay. Don't be shy, guys. Okay, we're going to go to Tina's question, where she's asking about who do we talk to arrange for a temporal artery biopsy?
Yeah, the truth is it depends a little bit where you are, I think. So different places, for sure across Alberta, there's going to be different surgeons doing it. So getting to know a little bit like where you are and who does it is part of the key. I think like many of the rheumatologists have their 1 or 2 people they know will do them. So same thing if you're not sure, if you call us on call, we're happy to help arrange or give you a name. In general, it tends to be ophthalmologists, at least around our center, general surgery. Will do them. I know in some of the other communities, it's more ENT or plastics. Um, those would be kind of the big 4 specialties that are doing them. But it
And
is, I think, very center to center dependent.
yeah, and again, outside of Calgary zone, it would be using rapid to get somebody quickly because the tools we have would be slower for
Yeah.
to talk to someone, right? So
Absolutely. Yeah. Like a GCA or a query GCA is a great rapid call to rheumatology. We never mind that. And it's much preferable to, I mean, I think some people sometimes don't want to bother and will send it by fax, but it's actually preferable by phone call because right then and there we can kind of start helping and we want to see these people fast. It helps us actually plan, the next coming days. So it's a good phone call. Mhm.
okay. And actually, just a related question on that for me, I have never seen a temporal artery biopsy done. And I'm just curious, how do they get a chunk of artery? Like, what does that process look like?
Yeah, I've never seen them here. I saw a few in Cleveland. They do. They feel for the pulse. And or I think some of them maybe do it under ultrasound, but the one I used to watch, she would just do it blind. She would feel for it, and then they just shave the hair, and they tie off the 2 ends, and they just resect the little hunk in between. It's your scalp is so vascular. You have so many like anastomoses. It bleeds a little bit, but there's generally no permanent trouble from the procedure. It takes about 15 minutes. Um, yeah, and the patient is awake, so they don't have to stop their anticoagulation. It's pretty reasonably safe. Patients often don't like the idea of it, but I think it usually goes better than people think it might.
Okay, very cool. So Jean-Pierre gets all the stars today for all the questions. Everybody else, there's still more ask questions. He's asking, with regards to vertebral involvement,
Hmm.
number 1, unique clinical feature, question mark, is dizziness, vertigo, a presentation for giant cell vertebral arteritis?
Yeah, it could be. Yeah, exactly. I feel like it's a really sneaky one. So yeah, patients who have kind of those like um, vertiginous symptoms, I usually think about imaging their vertebral arteries. Um, yeah, and it's usually bilateral, like just in my personal patient population, I feel like it's very commonly bilateral vertebral disease. So it's more common than I think we used to recognize, and that can definitely be a symptom. Yeah.
have a vast experience of an N of one, which presented with occipital headache
Yeah.
all in here. So it was like a occipital headache and actually had GCA as well.
Mm-hmm.
So I found when I did the search, there was like 2 cases in PubMed where they had both.
Mm-hmm.
And then went on to have systemic vasculitis and skin manifestations and MI and all sorts of things. So
Yeah.
very weird case. Uh,
Yeah.
but yeah, so that's, I think, guys, we're getting up to 12:55. So just, I see the QR code is in the box. Please take a sec to fill in the eval form. This whole series came because of your guys' feedback from Rheumatology 1. So really work hard to try to make these useful for you. So please, please, please take a second, fill it in. And Julie has a question. What's the increased risk in patients who've had aortic procedures, like valve replacement from bicuspid aortic valve with aortic root repairs? So
Is there a risk of having GCA
yeah, I think so. That's
after surgery?
like, do they have an increased risk of some sort of? I think that thing you showed at the beginning of all of those patients, like, was it from Sweden that had that sort of
Oh,
prevalence of that arterial disease? I think that might be what Julie's getting at.
oh yeah. So it's true. That's the only autopsy series that I'm aware of. It came from Sweden, like Malmo, this one city where they were sequentially, like histopathologically, if you just sectioned everyone and looked at everyone's blood vessels at autopsy, it looks like the prevalence is closer to, between 1% and 2%. So it's, there's a chunk of patients who just don't have clinical manifestations. So we sometimes find it by accident, right? They had a CT for some other reason, and it's like, oh, is this aortitis? Um, that definitely happens among people who have had aortic surgery. So I'm not so sure about bicuspid valve data, but I do know, actually, especially where I train, patients who have surgery to repair their thoracic aortic aneurysms, there is a chunk of patients in whom you will find incidental aortitis as the cause. They have no, and we call that isolated aortitis. Some of those patients have absolutely no manifestations of GCA or any other blood vessel inflammation, and they usually have normal inflammatory markers. Um, but we can find it in like 1% of these thoracic aortic samples. So it's uncommon, but kind of similar to the Sweden number, actually.
Julie
And
actually has a follow-on to
yeah.
clarify the question. What she meant was
Yeah.
a risk of complications if there's already altered anatomy.
Oh, I'm sorry. Altered complications from surgery to repair their aneurysms?
What did you mean exactly, Julie? Do you mean a risk like yeah, I'm not sure exactly what she.
It's true. Some of these patients do go on for surgery, and it is complicated surgery. Like vascular surgery on vasculitis is tricky because the blood vessels are sticky and they're fragile too. So it is more complicated than regular vascular surgery, which I think is probably already very complicated. Um, the best principles we know are to make the vasculitis as quiet as we can before they go in. Um, and then we have some recommendations kind of around how we hold the drugs or don't hold the drugs in the case of prednisone, um, to try and make it go as well as it can. But the surgeries can go well. Um,
Yeah.
some for
Okay,
sure. It's tricky, I think.
yeah, so Tina and Julie are both weighing in now. So clarifying it just says, sorry, if they later develop aortitis, will they have complications to their prior repair? And Tina is asking, like, is there an increased risk for aortic aneurysm in people who've had these things before?
In people who have had GCA before, people who've had
The aortic complications.
aortic
If they
complications.
actually have the aortic complications, does it kind of mess up their previous surgery? And Tina's asking,
Yeah. Yes, maybe. Yes. So the good news is like once they have graft in there, the graft is never going to get vasculitis because it's not native tissue. It's not the right antigen for the disease. But the bad news is wherever it was anastomosed to native vessel, that can still be affected. So once somebody has had aortic surgery, agreed, this is like a super important priority to like try and keep their vasculitis very quiet, if we can, so as to keep their graft okay. And same thing, that person would get like frequent imaging, um, usually by their surgeon, and then sometimes also by us, to try and make sure we keep it quiescent. Um,
The universe is hovering in that instance. Okay.
Yeah,
Everybody's monitoring. Okay.
that's right. I
Yeah,
was
right
worried.
to the minute, Allison. Thanks a million. This has been
Yeah,
so interesting and
yeah.
informative. And I think I speak for everybody who's all running off to clinics right now when I say thank you. Yeah, it was really great.
Oh, thanks. It was super fun to be here.
And people are all chiming in now and saying, thank you, Dr.
Yeah,
Um, you are a great presenter. You're really clear. So that's awesome.
that's nice. Awesome. Well, thanks so much for having me. It's really fun.